tell me when to share my screen, and I will...
Yes, most definitely, sir. Hello, everyone. This is Aditi Nanda, wishing you all a very blissful Sunday morning. It's indeed lovely to be starting the day on a learning note. We have been joined by the very renowned and respected Dr. P.C. Jacob, who has been paving and leading the way in the field of prosthodontics for more than 2 decades now. Sir, I wholeheartedly welcome you on the behalf of the entire team of the World Implant Expo. It's indeed an honor to have you on board.
Thank you, Aditi. It's indeed a pleasure for me to be here. And I'd like to first thank the participants who have actually joined us. And I hope a lot more of you will join us as we go along.
Most definitely, sir.
Sorry?
Ladies and gentlemen, I said it's needless to introduce you, but it's customary and I would not miss a chance.
Sure, go ahead.
Ladies and gentlemen, it is rightfully said, experience is the teacher of all things. And today, 25 years worth of it will be put across by our distinguished guest, Dr. P.C. Jacob. His expertise lies in the fields of implantology, full mouth rehabilitation, and maxillofacial prosthodontics. He has numerous scientific articles in many high-impact national and international journals to his credit. He seems to be on a spree of imparting his invaluable wisdom and skills, not just pan-India, but across the globe. Dr. Jacob is the key opinion leader for the 3M Dental Company and conducts training courses for the same. He's an active member of the Indian Prosthodontic Society and has been a member of the Executive Council, Indian Dental Association, and International Society of Maxillofacial Rehabilitation. So the more I speak, the less it is. We are all eagerly looking forward to learn the tips and tricks of implant impressions from you. Thank you, sir. We're really looking forward to today's webinar.
Thank you, Aditi. And again, I'd like to take this opportunity to thank all the participants without whom there is no webinar. And I would also like to thank my good friend and the chairman of the Expo, Dr. Shankar Iyer, Mr. Melvin, the CEO of this platform. Of course, both the Aditis, Aditi Senior and Junior. Aditi Senior is the chair of the scientific, and Aditi Junior is helping us. I don't know what your designation is, but I would especially actually like to thank both my associates, Dr. Ari Rajan and Dr. Shubham Apurve. Dr. Ari was with me for a year and has recently gone on to do other things. And Shubham has joined me about a month ago. And Shubham has really worked hard over the last 1 week to get some of these videos out. So I'm really hoping that rather than just give theory, we are actually trying to show the procedures and to help. And I'm actually looking forward to a very good Q&A after this. So I think without much ado, let me go ahead and share my screen. Okay. Let's go back here. Okay, can you see the screen?
Yes, sir. Yes, absolutely.
And you can see the cursor?
Yes, sir.
So implant impressions, like any other impression, the quality of the prosthesis that you give, whether it's a crown, implant crown, or a dental crown, depends on the quality of the impression that you make. It's like this. If you put in garbage, you will get garbage out. So what a lot of dentists sometimes expect is that whatever kind of impression we give our lab, they have to churn out something phenomenal for us. That doesn't happen. Okay. So, and when you come to implant impressions, the difference is that you have so many different components of so many different systems which you need to learn. Now, if you take this is from the Nobel Biocare company. And what you see on the left-hand side is an active component, an active open tray coping. And on the right-hand side, you see a replace select closed tray coping. Now, we will talk about what that means. What is an open tray impression? What is a closed tray impression? We are going to talk about those in detail. And one of the main differences between an open tray and a closed tray is that you can see this impression post sticking out. And this impression post sticks out of the tray so that we can unscrew and take out this post. And this part of the coping remains inside the impression. In a closed tray, this whole component stays on top of the implant and has to be taken out, connected to the coping, and then put back into the denture here. Now, this is what I would call an ideal impression. We have recorded the positions of the implants properly, but we have also recorded the soft tissue around well. And most importantly, we have recorded the occlusal aspect of the teeth very well. That is something that we need, that is key. Without that, the technician will not be able to make a good crown, and there will be a lot of occlusal correction to be done. So sometimes when we are making impressions, we come across situations like this. So here we have used two separate systems of impression coping. So here on the left-hand side, you have the replace select open tray copings. And on the right side, you can see these are the snappy copings from Nobel. And these snappy copings from Nobel are really unique because when you put your analog in, it actually makes a snapping sound. And so they are quite accurate. I would probably not use a similar system from any other company that I know of. Maybe there are, but I don't know about these systems. So unless we know the impression, the techniques properly and how to use this, we will not be able to make good impressions. So now, what are the goals of an impression? Number one, of course, is to capture the position of the osseointegrated implant fixture accurately. Absolutely. Number two is the surrounding tissue needs to be recorded well. So as you can see here, you have a very well-healed socket, osteotomy site. It has come like this because we have put in a well-contoured temporary crown. Now, in the anterior region, well-contoured temporary crowns are very, very important to contour the tissue for us. So we take an impression, we get a model with that, and then the technician can go ahead and fabricate a beautiful PFM crown, and you can see the PFM crown in position. I am personally not a big fan of zirconia. I don't like to use zirconia, and I'm sure other members would have different opinions, but this is my own personal opinion. I'd rather use PFM or Emax. Now, what about classification of implant impression? So basically, it depends on the type of the tray or the type of the impression coping that we have, and also at what level we are taking the impression. Okay, so when you talk about the impression coping, we talked about it. This is an open tray coping and this is the closed tray coping. So an open tray is also called a pickup and a closed tray is also called a transfer. Transfer because your impression coping will remain on the implant. You need to unscrew and take it out, connect it to the analog and then put it back into the impression. And the level of impression, of course, will be either you have a fixture level impression that is at the top of the implant or at an abutment level impression. So now this is an abutment of a replace select implant. And this is the snappy system that we were talking about. And I will show you a video of how we use this system. So most of the impressions that we take are fixture level impressions. And in some cases, we do abutment level impressions as well. So Dr. Shubham made this beautiful chart for us. So if you say you have closed tray and open tray here, interarch space, if you have less interarch space, then it probably be better for us to use a closed tray impression. Provided the the implants are not at odd angles, then it becomes difficult. Okay. And in a pickup impression, you need more space because you need to be able to unscrew and take out the impression post. What about the tray? You don't need to modify it. You can just use a stock tray. In pickup impression, and actually in a closed tray, I would prefer to use a metal tray wherever possible. And in a pickup impression, you need to perforate the tray because your impression post has to come out. And therefore, more often than not, we will use a plastic stock tray, or we will make a custom tray. Then what about splinting? Splinting is of course not possible in closed tray copings, and it is possible. So when you have multiple implants there, then we more often than not go in and do a pickup impression or an open tray impression. What about the precision of the impression? Like I said, we need to take it out and then push it back into the impression. So there can be some inaccuracies that can happen, but normally they don't. So in a closed tray, because the coping remains inside the impression, there is less distortion, especially if they are splinted together. If it is a single impression, then what happens is sometimes when you're trying to tighten the abutment onto that, the hex can move. And if that happens, then your crown will not fit the tooth. And what about alignment of implants? The more accurate, the impressions are more accurate if the implants are parallel. And if they are not parallel, then some level of inaccuracy will be present there. Also, you cannot splint them. On the pickup side, because you can splint them, you get a higher level of accuracy. So what about an open tray? Okay, so like I said, the impression coping remains inside the impression, and if you're splinting them, you normally do it with GC pattern resin, which is an acrylic material, or with composite. Okay, and the advantage of an open tray is that the effect of implant angulation deforming the impression material is less, and of course you don't have to put the coping back into the impression. Also, if you have multiple impression copings, then you can splint them together and you get much better results with that. So this is an example of an open tray. This is a Zimmer open tray coping, and this is the analog. So let's watch a video. So it's imperative, whether it is closed tray or open tray, that you take an X-ray whenever you are connecting an impression post in the mouth. So let's watch this. So you can see it's in the mouth. I've got some natural teeth there, and when you have natural teeth, you must do gingival retraction. It's not a choice. If you have equigingival margins like I do, you must retract over there. Secondly, you have to select the correct size of tray, and here I've used something known as Optrogate. Another very important thing is you must apply tray adhesive. Okay, it's not enough if it is perforated. Then you take your light body and put it around. Take your air syringe. Meanwhile, the putty is being mixed. You must put light body on the putty, okay, so that you get better occlusal anatomy being picked up. Like I said, you remove the occlusal pin out and your transfer coping remains inside the impression. So this is a open tray impression. Now, for bite, most of us use these bite registration paste. The problem with that previous material is that there is rebound in that. One of the most accurate materials to use is something known as AluVax. Okay, it has got aluminum particles inside it, and this product is actually now available in India. Okay, so AluVax is, I feel it is a much better product to take bite rather than your bite registration paste. The other thing is to take the impression of the opposing. You need to use a rim lock tray, spread some alginate, use good quality alginate when you're taking that. If you don't have a good opposing, you will again have problems with occlusion. Sorry. Now, in most cases, we can use a stock tray, but there are times like here where a stock tray just doesn't fit. So you need to go in, take an alginate impression, get a custom tray make. In our clinic, we use light cure tray material. We fabricate our own trays. We don't send it to any lab. Of course, if you are lucky like Varun, he has a full-fledged lab next to him, so he doesn't have to worry about it. So you make a tray like this, okay, put a double wax spacer inside. And then here, I don't use putty. When you make a special tray, please don't use putty in that. You need to use medium body with light body, or at least complete light body. Okay, either you can use VPS or you can use polyether, and I will talk about polyether, in a little bit. Right, this is a polyether impression. So you can see here, this is an all-on-6 case, and what I used to do was I used to make an impression, again make a custom tray with that, and then splint all of them together and pick them up in an impression. And this is with the analog. The reason I stopped using polyether was that a couple of my impressions got locked inside, and I had a hell of a time removing it. And then I decided that I'm not going to use polyether. So I have actually completely stopped using polyether. Maybe I'll go back in and try it again and see how it is now. So that's about your open tray impressions. What about closed tray impressions? Like I said, they are placed either on implants or multi-unit abutments. Okay, so when you remove the impression comes out. Your coping stays on the in the mouth. This is a Zimmer. This is actually an implant carrier which can be used as a closed tray coping also. Dr. Shankar likes this very much. I know in most of his cases he uses these closed tray copings. And these are closed tray copings from, these are Nobel replace closed tray copings. I very rarely use closed tray impression copings actually. And so you remove that, you connect these two together, and then you push it back into the impression. Unfortunately, I wasn't able to make a video on the closed tray, but you can just go online and take a look at that. Then, of course, you have abutment level impressions. Okay, so you attach an abutment onto your implant, onto the fixture, and then you take an impression at that level. So take a situation like this. Again, this was these were Nobel active implants, and we had to correct the angulation. So to correct the angulations, we had to put multi-units on that. You have to make sure that you have enough prosthetic space when you do that. That means you need enough place for your prosthesis to come. So here, if you can see, even with the multi-units there, we have more than enough space. So again, we have connected them together with pattern resin, and this is the impression that we have made, and this is the final prosthesis that we have given the patient. So this is an all-on-4 case. This was one of my patients, and we decided to record this. And of course, Shubham did a great job with recording this. So you can see here, these are the abutments that are there. These are the impression copings which go over them. So you connect them properly. And if they are visible, you don't need to take X-rays. If they are not visible, you still need to. Again, I use wire. I used to use floss before, but it's just too cumbersome. And I get good results with this technique. So I use this technique now. Again, we have taken a stop tray. This tip that you see it's an excellent tip because you can put it around, you can break it and put it over the same technique. The technique does not change. Okay, you need to expose them, and you need to know what is the setting time of the material. Okay, so this is affinite, so its setting time is 3 minutes. So you can see here, we have picked up a good impression. Now we are connecting the abutment level analog. So because they are splintered together, they will not move. But in this case, even if they move, it's okay because it's round, so it doesn't matter. It will not change. And then you pour up a model like this. Now, these are the two main techniques. So you have an open tray technique and you have a closed tray technique. Now, there are some modifications that are there. The snap-on impression is a combination of both of these, as you will see here. So we remove, this is a WP implant. So we have put the abutment in position and we put the abutment screw and tighten it down. Then you put the snap-on coping there, which actually snaps on nicely. This is the active implant. Again, tray adhesive is very important. Metal tray adhesive. Same technique, no change. Syringe it around. And then in this case, allow it to set 3 minutes. If it is 3 minutes, you have to keep it 3 minutes. That's something I learned from Varun. He has a timer. So I've also bought a timer now. If it is 5 minutes, it is 5 minutes. It doesn't matter. Again, you can see how the snap-on has been picked up. Then you remove the abutment from the mouth. And you can see here, this is your analog, abutment level analog. And this is, and then you connect them together. You connect them together and it snaps on again. That's it. So I've taken it out again just to check. That's it. And then you send it to the lab and they will go ahead and process it. Now, when we talk about implants are not just fixed. You know, a lot of dentists I find are just hung on the fixed concept. Removable plays a huge component in implants. And this is a situation, senior citizen, 70 plus. What is the best thing we can do for her? Put in 2 implants with some good attachments and give her a denture. That's it. And these are Straumann tissue level implants. That is the one we prefer to use, but you can use any MIS. They have something known as the Novalock. If you're using Nobel, you'll get locators. If you're using MIS, they have their own attachments. Each system has their own attachments. Okay. And then the way we take impressions is we put these, the male components inside. You can get them either in metal or in PEEK. And then we take an alginate impression. We again make a custom tray and we again use medium body and light body to make a final impression. And in the final denture, we pick these up in the mouth. These are PEEK. That's why they are white in color. Okay. They are a phenomenal way of rehabilitating a patient. So don't get hung up only on fixed. Okay. I can show you case after case after case of removal, especially in the maxillofacial work that I do. And I will show you one case of that. Like this. Can you believe that on the left-hand side, this whole thing is a fibula? That is the bone taken from the leg along with the tissue, and we are giving the patient a denture. Now, because this height is so much here, I would definitely never give this patient a fixed. So you can see how we have gone ahead and made the impression, the same technique. Again, we take an alginate impression. We attach the PEEK male component. Sorry, this is a little messy, this video. I'm very sorry about it. And then we go through the same technique. I hate these tips from Dentsply. It is so difficult to extrude material, but their material is fantastic. And then we go ahead, and after 5 minutes, we get a beautiful impression. when I have no experience with, digital in implants. And let's see, in the Q&A, I would like Dr. Varun to come in and give us a little bit about his insight. I have some experience in fixed, and I will talk about that. But in removable, I just don't know how you can get nice, borders like this, functional impression like this. I don't even know if it is possible. But finally, you give a denture like this, and the patient is absolutely fine. She can eat anything she wants. So don't get hung up on doing only fixed. And this is the last case. This is with polyether that we are taking. This case is about 8 years old now. Again, she has a fibula here. She has locators. These were Nobel implants. Okay. And then we placed locators. Again, we take alginate impression. We make a custom tray. But the difference is here you have to use polyether adhesive. You cannot use VPS adhesive over here. And then you make a final impression, and that's the denture that the patient has got. She's been wearing it for the past 5-6 years. She can talk properly, she can eat properly, her aesthetics are fantastic. To do something like this in fixed would be very, very difficult. And that's the X-ray. You can see the fibula beautifully. It has, this case done by my good friend, Dr. Anjan Shah, at Jain Hospital in Bangalore. I work with two fantastic teams. One is in Narayana Hridayalaya and Mazumdar Shaw, and one is at Jain Hospital with Dr. Anjan. So, what is your take-home message? Your take-home message is that a successful implant prosthesis will rely heavily on good impression techniques. Don't expect to give garbage and get fantastic. It's not going to happen. You want good prosthesis, give good impressions. Listen to your technicians. Technicians tell me, sir, I get shouted at if I tell anything to the doctor. No. We can make mistakes. I make mistakes. I repeat impressions. There is nothing wrong with that. In fact, your patient, sometimes you feel, oh, if I, repeat my impression, my patient will think I don't know. No, your patients appreciate you. That they say, doctor, I'm happy that you're willing to redo it, put in your time and your material. Trust me on this. I've been doing this for a long time. And if a patient says the other way, then he doesn't deserve to be your patient. No point treating that patient. Okay? An ideal impression records the position, depth, angulation, rotation of the head, soft tissue contour, or the emergence profile. And each impression technique has its indications. And it is up to the clinician needs to choose the right technique based on the situation. So it is up to you. You need to have the knowledge. And then based on that, you will choose the right technique. So I hope that this will give you some insight into what you need to do. Try to be the best that you can. Try to get each impression like a textbook impression. It doesn't happen always. It doesn't happen to me always. But try for that. Reach for the stars and you'll reach somewhere close. Thank you very much.
Thank you so much, sir. Your energy, passion, and dedication for teaching certainly inspires us in more ways than one. And I'm sure even this brief session with you will profoundly improve the way implant impressions are made. So thank you for sparing your invaluable time and sharing your wisdom with us, sir.
Thank you.
So shall we take up some questions?
Yep. The boss is here, Varun Acharya.
Hello, Dr. Varun. Thank you for joining in. Sir, Dr. Varun asked that some people suggest to use non-engaging open tray impression copings and sling them together for a full arch case. What do you think of this approach?
I agree with that. That is an option that you can use, but only for a full arch case.
So you can share more insights on this?
You see, in the case of a full arch case, you're not engaging the hex anyway. Okay, because you have, let's say you have 4 implants or you have 6 implants. And to try and engage the hex in all of them would be virtually impossible. So since you are not engaging the hex, you don't need to record the hex, actually speaking. So as long as you splint them properly, I think it's fine to use non-engaging. I would go with that.
Okay, understood, sir. The next question is asked by Dr. Kiran, and the question is, if not polyether, which is the other material of preference for medium body or light body impression?
You can't take only light body. You have to use light body and medium body, or light body and heavy body. See, I'm not against polyether. I just had a couple of bad experiences, and patients were quite irritated with me. So that's why I pulled back from polyether. Polyether is actually, if you look at the literature, it is the most accurate material. But putty and light body, I think, I've not had too many issues with putty and light body. Again, it depends on your impression technique. Materials, they have been researched thoroughly, so I don't find them to be a problem. But medium body and light body, what I use now in a custom tray is VPS, medium body and light body. You can choose it from any company you want. What is that? DentistChannel has it, and I'm sure there are a whole bunch of other companies. I think I've tried out the one from Colteen also, and I was not very impressed with it. So you can, you need to, I feel that you need two types of impression materials in your clinic. Like I have two types of putty. I have a soft putty, which actually Dr. Varun introduced me to, that is Avu. And I really, now I really do like it. But for implant impressions, I normally go for Affinis, which is a harder putty. So that is what I use. And then I have medium body from DentistChannel. And I'm not advocating any of these companies. Okay, this is what works for me. You can choose any any material that works for you.
Understood, sir. So the next question is that which tray adhesives can be used for metal trays?
All companies give you tray adhesives. If you're using polyether, you have to buy polyether specific tray adhesive. And I think other than 3M, I don't think anybody has that. And, if you're using VPS, you can use any company.
Okay, understood, sir. And sir, one anonymous participant asks us, why don't you use zirconia crowns, or why don't you prefer them?
To me, the monolithic zirconia is like stone. It's extremely hard. If you take one monolith crown and one zirconia crown and you drop it on the table, you can make out what is the difference of the sound there. I personally, in my mouth, have cracked one tooth. I think it was because there was a zirconia crown. So this is just a personal preference of mine. I'm not saying don't use zirconia. Or if you are, use translucent zirconia because it's not as hard. And I also like Emax because I can bond it to the tooth. Yes, people say you can bond zirconia. I'm not so sure about it.
Okay, understood, sir. So why is only light body and medium body used with custom tray and not putty?
Because you need a lot more space if you want to use putty. You can never have 2 millimeters. You cannot put putty in a 2 millimeter area.
All right, understood, sir.
When you make a custom tray, you're keeping that, you're putting that 2 layers of wax because you will get uniform impression over there. That is the reason why you can't use putty.
Right. Okay, understood, sir. So you prefer analog placed in impression while giving to the lab, or lab people will place because sometimes while taking it during their journey to the lab, it may get distorted?
I place my own analogs. I connect them, and I bubble wrap. I get my staff to bubble wrap the impressions and send it. Because I've had problems where the hex has moved because if you're not careful, if you have a single impression with a open tray coping, When they are tightening it, they can just move it, and your implant crown will not fit. So I connect all my cases myself and send it to them.
Okay, understood.
Unless you are Varun Acharya, and then you have to just walk across the room, and you don't even have to walk. They will come and pick it up. Yeah.
Rightfully said, sir. So Dr. Varun says apparently using non-hex post in a full arch is more accurate because there is less force on the splinted post during retrieval. Right.
Got it.
Okay. So addition silicone or condensed silicone, which is better?
Condensation silicone should not be used in the mouth. It is only in India that we put condensation silicone inside the mouth. Internationally, they don't use it. So that is why you get one bucket of it for quarter of the price.
Okay. And so why should it not be used?
Tell you the truth.
So why should it not be used?
Its dimensional accuracy is nowhere near what the accuracy of your addition silicone. So I would use it for, making, what do you say? Like if you have crowns and you want to make, like if you're doing veneers and you want to make a jig, I would use it for stuff like that. I have never used condensation silicone ever.
So is abutment level impressions more accurate than over fixture level?
I don't have an answer to that. Maybe Varun has. I'm not sure. I feel that fixture level impressions are better. But, with the snappy, I have never faced a problem with fit or anything. So I don't know what the literature says, but in some cases, I feel both of them are accurate. But they say that fixture level, impressions are supposed to be more accurate, but I'm not sure. That is one question where I don't have an answer. That's the truth.
Okay, sir. So our participants wants to know that if your decision workflow on when to use abutment level or implant level while restoring multiple unit implant superstructure, how do you decide on the impression?
Your decision workflow on when to use abutment level. Okay. So it will depend on the angulations of the implants that we have got, depending on the bone that we have. Now, if you have too much of divergence, like that case that I showed, there was a deficiency of bone. So to try and get all the components parallel to each, to try to get them parallel, we use the multi-units. But like I said, if you use multi-units, you must have enough prosthetic space there. If you don't have enough prosthetic space, you are in trouble.
Sir, shall we try bringing in Dr. Varun?
Oh, bring Varun.
Yeah, I'll try to put him on panelist. Right.
What is the indication of abutment level and implant level impression? How to decide? Is it?
Dr. Varun, I think you've been promoted to panelist. Please try joining in.
Thanks for the promotion. Can you hear me?
Yes, yes, you're audible. Welcome aboard, sir.
Hi. Jacob, you're invoking my name too much during this presentation. So I kept hearing my name and I'm like, no, I now need to join and storm in on your presentation.
What is your opinion on this, Varun? Abutment level versus the accuracy of abutment level versus fixture level?
So if we are talking full arch,
yeah,
and we are splinting it all together, I don't think there's a difference in the accuracy.
Okay.
However, if you're doing abutment level, there is one more spot where you can make an error in the sense that you may not have connected the multi-unit, for example, properly to the implant. It may have been sitting off of the hex or whatever, some trivial mistake like that. So there is one more layer of a possible error with the abutment level impression because you've not seated the abutment properly, because that's what it is. But if you're doing
the impression itself.
No, if you're doing, let's say like you're treating it like crown and bridge and you've just placed standard abutments on all of them and maybe a packed retraction cord and you're making an impression, I think that's terribly inaccurate compared to a fixture level impression.
Yeah, I mean, I wouldn't see when I'm talking about that. I'm talking about at least a snappy. I'm not even talking
Right,
about
right, right.
That is not standard of care at all.
Yeah, but a lot of people do that because they then tell the lab that, hey, this is a tooth prep. This is not an implant, so charge me less on the lab bill.
Yeah, I know,
Yeah.
but that is not standard of care. So.
That is not, no.
The other thing I wanted to ask you, what is your experience on with, I have very limited or I have no experience with implants using a digital scanner.
Yeah. So, see, I've used the scanner now since 2019. Out of that, very few have been implant cases because we always had some limitation of what we had in the lab. And it used to be the 3D printer. Now we have a good 3D printer. So we're going to be doing more. But in my experience, the occlusion seems very nice. The fit itself is nice, but the contacts tend to come out a little bit tighter than what I would like. But then that also could be that the lab is a little bit overcompensating the contact, because what happens in these screw mentables, especially zirconia, these screw mentables, let's say the contact now comes open. They've done it digitally exactly right. The contact looks perfect for whatever reason. The mill, it came out and it's a little bit open.
Yeah.
Now that means I have to send it back to the lab. It's already been luted in the lab to the tie base with resin cement.
Correct.
Now I have to send it back to the lab. The lab will take about 15 minutes to first retrieve the tie base from this from the crown, because they have to burn out the cement in the furnace. Then they have to wait for that to cool. Then they need to do the add-on firing for the ceramic. That's going to take another 15 minutes. Then they need to wait for that to cool. Now we're already at half an hour, 40 minutes. Then they need to lute it back together and send it back to me. So now we've added another 10 minutes to that whole thing. So now we're looking at 45 minutes of waiting when there's an open contact. So what they tend to do is they tend to overbuild it. So I can't really judge, but results are very promising. It is more expensive because you have to, if you're doing multiple units, especially, you'll want to 3D print the model. And then here's the best part, which nobody realized. You also have to 3D print the gingival mask.
Right.
Which we take for granted when we're doing analog impressions. Even that gingival mask is 3D printed. So if you want to 3D print that, it's a separate tray, it's separate material, it's separate blah, blah, blah. So the costs like kind of spiral. And if you're talking full arch accuracy, it's not there yet for intraoral scans.
Not there yet, right?
Yeah, because you're still stitching multiple images, whatever scanner you're using, your Shining 3D, your Trios, your Serec, your... I've now tested, I think I've tested like 7-8 scanners at this point. But whatever you're using, full arch, everyone agrees is not too accurate. Then that's when they do this photogrammetry, which is now very, very expensive and not available in India. So we still have a good old-fashioned material.
No, the reason I'm asking you this question is because more and more people and more companies are pushing this, that you don't need to know how to take an analog impression, which according to me is garbage.
Yeah, so there's always the sort of ulterior motives of the company, right? They even they even tell you that if you buy an intraoral scanner, your results are going to be much better. But I would say that an intraoral scanner will make you a better dentist. Right. Because you're going to be seeing on the screen how bad your preps are. That happened to me, right? So I got an intraoral scanner. I thought I was the greatest. And then I took the scan and I looked in the screen and my jaw dropped because I'm seeing at such high resolution how bad my preps were, like what issues were there with it and what needs to be changed. So it will make you a better dentist, but not willing to change your skill and just taking a scan and expecting a better result than analog is not going to happen.
Right. Yeah, that's what I wanted.
Yeah.
I know that a couple of schools in the US are kind of shutting down their analog this thing and they're doing everything digital, which I don't know.
Yeah, that's pretty ridiculous in my opinion.
Yeah.
I'm enjoying this session so much. It's great to have two amazing prosthodontists on board. So thank you so much. Shall we take up some questions, sir?
Sure, go ahead. Is translucent zirconia strong enough to withstand? See, I use Emax for my posterior crowns. As long as you bond them well, I don't think there will be an issue. I have limited experience with translucent zirconia, but to me, I don't think you need something like monolith zirconia over there.
Okay, understood, sir. So Dr. Kaustav asked that, can I use intraoral scanning machine instead of putty impression material to implant placement? I think that's what the discussion has all been about.
No, you need to still, you see, what a lot of dentists are thinking is that, you don't need to learn the analog method, but you can do digital. That doesn't work. You need to know the analog method before you do it. And there are limitations with scanners.
Right, that's rightfully said, sir. So how can we evaluate our implant impression?
Well, you have to check everything. Like if you go back to the impression that I showed in the beginning, all the areas must be covered. And where I find problems is the occlusal aspect. If you don't put light body and record it, you will not get all those grooves and everything properly. Then you will have problems with your occlusion. So I find that wherever I make mistakes, I normally make mistakes that my light body has not flown properly.
Okay, understood, sir. So how can we evaluate on X-ray whether our coping is properly placed or not?
Well, they should fit properly. Like, can I go back and show that one?
Yes. Yes. Please show.
Share screen again?
Yes, please, sir.
Okay.
Also, I would like to extend thanks to Dr. Varun for joining in. It made things a lot interesting altogether. Thank you, sir.
Oh, no worries. Happy to be here. I'm still hanging on in case Jacob
Yeah.
decides
Hang
to
on.
invoke
Yes.
me again.
Okay, I need to go back to share. Why am I not able to share?
You can unshare it and share it again. Okay, it's working.
Is it coming?
Yes, sir. Yes.
Let's get this Q&A out. Okay. Yeah. So if you look at this impression on the right side, you can see that, you don't actually need these flanges very well, but it's better to record everything. But more importantly, you can see how beautifully the occlusion part of it has been recorded. That is the most important part. And then all around, there must be no voids in the important areas. Like if I get a void here, I don't care because it's a palate. So that is very important. And same thing here also, if you look at this impression. I don't need these areas actually, so I normally cut them off. So if you see, can you see this? Are you able to see the X-ray?
Yes, sir.
So you can see this is the Zimmer implant and this is the connection, and there is no space here at all. That's how it should be. If you get a space in between them, that means your components are not attaching properly.
Jacob, I'd like to chime in over here. In Zimmer, actually, the new implant, the TSX.
Yeah.
So now that is a platform switching.
Okay.
But that's not really the issue with it. If you see, even in BioHorizons, it's the same connection, Zimmer and BioHorizons. When you see this X-ray,
okay,
you will actually see a gap between the post and the implant. There is a small gap, and the way it works is the bevel of the implant and the bevel of the impression post, they contact only on the sides. Then there is a radiolucent gap in the middle, and then there is again radio opaque. So there is like this sort of
but that will be very confusing to somebody who's new.
Yeah, it's not looking at it is very difficult. You look at it and you'll think it's open, but it's not open.
Yeah, but normally it is like this. All components are supposed to be flush normally.
Yeah, here you will see the edges are flush, the middle is flush, and somewhere between the middle and the edges, you're going to see an opening.
Okay. Yeah, I think let's not confuse more. I think more of the people are like on the basic side.
Yeah. No, mostly it looks like this. You're right. But there are just these some systems which are more confusing.
Exactly.
Understood. So which alginate do you use, and also which open trays for implant impressions?
You mean company-wise?
Yes, sir.
Okay, I use Cavex from Cavex alginate. It's a Dutch company. You can use any material that works for you. This is just something I use. And my open tray impressions, I have couple of companies. You see, the problem with open tray impression, with stock impressions is none of them are made for Indian patients. So I buy two or three, and then sometimes if one doesn't fit, then I'll do the other. Sometimes none of them fit, and I have to take an alternate impression and make a custom tray. Thankfully, it doesn't happen very often.
What do you mean when you say they are not customized for Indian patients?
The size. See, either they are too big or they are too small. So even if you look at our complete denture impression trays, how many of them actually fit our Indian patients? Very few. They are not made, and the ones that are made here are garbage. They don't have any contour.
Right, understood, sir. That well answers the doubt. The next question is that in a free fibula case, when we have to give a stent, do you prefer making the impression before debulking and prefabricate the stent, or the impression is made after with the locations in place, with the locators in place?
You mean temporary denture?
Yes, sir.
So it depends on how much of soft tissue there is. If there is too much of soft tissue, then I will just make a plate. Okay, and then connect that plate onto the, after debulking and doing DGER, we will connect it together. We will wait for 1 month, and then I will remake another impression and remake another temporary denture for the patient. If they're using only this thing, fat and fascia, then there won't be that much of soft tissue there. In that case, I will fabricate a denture and connect it up in the. Oh, sorry. How did this come on? Then we will connect it in the OT.
Understood, sir. And sir, how can we retrieve the implant impression if it gets stuck in the undercut, like the case you said for polyether?
Yeah, that can be a nightmare. So I've had to actually go in and cut right through from the lingual to the buccal and take it out in. So that is the issue with polyether. You have to be extremely careful when you use polyether. So that was the reason why I stopped using polyether, actually, because one of my patients, it happened and it was a nightmare for me.
Understood, sir.
Great material, but you need to know where to use it.
Okay. Yeah, well said. Sir, your thoughts on temporization in posterior area before impression taking?
I don't temporize in posterior at all.
Okay. So the next question is by Dr. PR.
After 3 months, go in and do stage 2 and then temporize. Is that what you're talking, or is it immediate insertion?
Prior to impression taking, sir.
No. What I'm saying is it immediate loading or is it temporizing after 3 months?
I think it's about immediate loading.
No, I don't do any immediate loading in the posterior.
Okay. So putty and light body or monophase, which is better? Your thoughts on it?
They both have indications. I've shown the indications. Normally, for just stock case, I would just use putty light body. But like any custom tray that I make, I will use monophase.
Okay, sir. So next question is by Dr. Kiran, and the question is that in an implant-supported removable obturator impression, where we have to report the defect as well as the teeth, so do you prefer custom tray or stock tray? And also the material of choice.
I will take a stock tray alginate impressions for all my cases. I build up the defect 70% with wax and the rest with alginate. And then I will make a custom tray and take a monophase impression. Always.
Okay, sir, understood. And so one last question for the session. You have been very patient throughout. That can you please highlight on jig trial, how to do it, and whether it is necessary for every case or not?
I don't do jig trials for single implants. I never do. For 2 implants, sometimes, but usually not. But for a full arch, 100%. And normally the lab will make the jig for me. They will use temporary cylinders. And they will connect them up together, and then I will check it in the mouth. I will put 1 screw in and see how the fit is, whether it's fitting properly or not. If with that 1 screw everything is not seating down properly, then there is a problem in my impression. Some people say that, GC pattern resin is not accurate enough because you can get distortions, and some people use plaster to connect them up, but I have never done that. I have never done it.
Understood, sir. So your preferred attachment for implant overdentures?
Each company has their own overdentures. I've stopped using ball attachments now because locators, Novalock, you can, each company will have their own attachment. I don't use ball attachments anymore. I feel that these locator type attachments are much better.
After you introduced me to Novalock, I think they are my new favorite attachments.
Fantastic attachments, right?
Yeah, I think even over locators, like Ostim doesn't even call it locators; they call it port attachments or whatever.
Yeah, but, that they just modify it.
Yeah. Supposed to be compatible, but what I really like is the Novalock, which you introduced me to.
The tissue level with the Novolocks are really good for denture cases. So yeah.
So one last question, maybe for both of you. Can you please both suggest some good literature or textbooks for implant impressions and basic implantology?
Okay. So I actually went through a nice Indian article. I will just see if I can. I was very happily surprised by this article. It is called, what is it called? It's in the yeah. So you can get it for free online, actually. Let's see. So it's in the International Journal of Dental Research, 2021. It's called A Comprehensive Review of Impression Techniques in Implant Dentistry. It is by Shweta and Chain from Mumbai and Rajiv Gandhi. I think it's a great article that they've written. Really, I was very impressed by it. A lot of the theory that I actually took from their article. So that's a great article to read. Textbook, I don't know. Everybody says Mish. I have not read too much. You have anything in mind, Varun?
Everyone says Mish, but even I've never read Mish. And also, if you talk to people, you'll realize that Mish has certain controversial or outdated concepts at this point. Yeah. Things like progressive disclusion and stuff which nobody really does. So I actually don't recommend Mish. I think something that you have suggested is perfect because it's a good starting point.
Yeah.
And then when you want to read a little bit more about something like a closed tray or an open tray or a digital, then you search for those specific articles.
Right.
But I think this is probably the best way to do it, starting with the article you shared.
Yeah, that's a fantastic what do you call it, starting point. I was really I lost. How did I lose you? What did I do? Can you see me?
Yeah, yes, we can see you.
Fine.
So you can just click on your Zoom and you'll be able to see us again.
Oh, my Zoom. Okay. Nope, that's not happening. I have the screen on top. Participants. Okay, I got it.
Right. Yes, sir.
I think articles are much better than going in and actually reading a textbook. That's what I think. Good articles are there. A lot of them are free.
Even better are these webinars, sir.
Yeah.
We have had a great time learning from you. And it was one of the most engaging webinars that we have had so far.
Thank you so much.
So thank you so much for sharing your invaluable knowledge.
Who was there?
Most definitely, sir. And I'm sure our audience must have had a great time learning from you. And thank you so much, Dr. Varun, for joining in and spicing things up.
Thank you. I do keep things spicy. What can I say?
Thank you so much, sir. I wish you both a great Sunday. Have a happy weekend. And thank you so much once again.
See you. Bye.
Bye-bye.
Bye, Jacob. I'll call you now. We have lots to chat about.